I'm very excited to be here today to talk about our work with urban refugee youth. I want to acknowledge my co-authors, Dr. Moses Okumu, Robert Hakiza, Simon Wima, Vibhuti Kacholia, and Dr. Peter Chimbade. There are 79.5 million forcibly displaced persons around the world, and 40% are under 18 years old. And we know people in humanitarian contexts experience increased exposure to sexual and gender-based violence alongside unmet sexual and reproductive health needs. And we also know there are many barriers to accessing HIV prevention and testing in humanitarian contexts, but these are understudied among adolescents. They're also understudied among refugee youth who live in urban areas. Most of the research has been conducted in settlements. So we focused in Uganda. Uganda hosts 1.4 million refugees, and we focused on the 80,000 refugee and displaced people living in Kampala, the urban setting. A previous study we conducted, we found only 56% of refugee and displaced youth in Kampala had ever been tested for HIV, and we also found suboptimal STI testing. We found social ecological factors such as stigma and food insecurity were associated with both HIV and testing practices. So we actually applied Campbell and Cornish's conceptualization of health enabling social contexts, and we specifically looked at material contexts, which includes access to resources such as clinics, economic security, transportation, and symbolic components where people's dignity and value are respected and they're able to view themselves and others in a way that help them engage in healthcare. And so we conducted a qualitative study that involved 5 focus groups with refugee and displaced youth living in 5 of Kampala's informal settlements in Zambia, Katwe, Rubaga, Kansanga, and Kablagala. 2 focus groups were with young women, one aged 16 to 19, one aged 20 to 24, and 2 with young men, same age breakdown. 1 focus group was 16 to 19, 1 with 20 to 24, and 1 with refugee youth sex workers. So we had a total of 44 participants. Most were from the Democratic Republic of Congo, followed by Rwanda, Burundi, and Sudan. And most identified as refugees, and 2/3 had ever received an HIV test, and over 3/4 were unemployed. So these are basically our findings in a snapshot. For material context, participants discussed transportation barriers, a lack of private spaces due to overcrowding and their living conditions, literacy challenges, and also language barriers. So because there's refugees from so many different places in Kampala, there's actually needs for translation in many different languages. We also found symbolic contexts were associated with HIV testing practices, including religion, medical mistrust, and inequitable gender norms. So for the sake of time, I'm only going to highlight a few examples. For example, in the material context, many people said because of the high rates of unemployment among refugee and displaced youth, they didn't have funding to travel to HIV clinics. And so on the bottom quotation, one woman is describing, even if there's a free service, if people have to travel to get there, they're not able to make it to that HIV testing site. We also were exploring HIV self-testing, and participants described that people are living in really, really crowded spaces. So it's hard to find even a private space to do the test. And there's also challenges accessing garbages that are private. So if you have a self-test kit that's used, where are you going to dispose of it where other people won't find the result? And literacy was an issue. And people said, even if you have illustrations, it might not be enough for people who've never accessed formal education. You might actually have to show people in person how to use, for example, an HIV self-test kit. For symbolic context, religion was an interesting finding because people talked about religion as a way that they stayed connected to their communities and countries of origin, so other refugees. And they also suggested that that's a great place to meet lots of youth if you want to engage youth, but you may have to do some work with religious leaders who might have prejudice. But we've also found this in other studies where you can engage religious leaders and have them be part of a solution for promoting sexual health. And others discussed there was mistrust of community-based outreach. So people who didn't know outreach workers coming in and offering testing. Some people, as in the first quotation, said, are they real people that are supposed to test? Are they trying to give us the virus? And others discussed widespread experiences across trajectories of coming as a refugee and being as a refugee, of sexual and gender-based violence, embedded within inequitable sexual relationship power dynamics. And those really constrained women's ability to have sexual agency. So altogether, social environmental factors shaped engagement in HIV prevention and testing with urban refugee and displaced youth. We need to consider transportation costs, so beyond offering free testing, crowded living conditions, and the need to access private spaces, literacy and language. We also can really leverage the role that religion continues to play in refugee youth's lives by engaging with religious leaders. So we really need to think for developing health enabling environments. We do need to provide technical information, resources, and skills alongside addressing the social circumstances, cultural norms, and values that constrain people's agency over addressing their sexual health, while leveraging the strengths, resilience, and resources in refugee and displaced people's communities, especially those among refugee and displaced youth themselves. Thank you so much.